My first instinct is, wait, hold on, can we swear on this podcast?
You can swear as much as you like.
Right, bullshit. And the reason is that as an on-jobbing doctor, it's rare that you see an innovation that you think, oh, that's useful to me, because it doesn't solve my problem. Medicine is language. Therefore, suddenly the computer in the room could understand what's happening in the room. So it opens up all these black boxes, all this data, all this productivity. People spend a lot of time thinking that they want to do something and never trying it. And that, I think, is one of the most dangerous states of humankind, because basically what you're doing is you're waiting for your life to begin. Third and most controversially, if you really want to do it, quit your job. It's a bit like a terrapin. It will grow to the size of the tank that you put in it. But quitting your job is like jumping into the ocean. Like, it's cold, it's sweet, you might drown, but like you're there and you're going to swim and you're going to expand to the size of the ocean. The other day, it taught us everything was on fire and there was a disaster everywhere. And then I was just like, well, no one's actually dying. Right. I was the heart attack centre registrar for like 3 years at the Royal Free and at Barts. And like, people come in there with cardiac arrest, they're at death's door, and you're going to make decisions then, and that's stressful because if you make the wrong decision, they will die. That's stress. This is just fun time. I think about large language models specifically as like a combustion engine. Don't sit on a combustion engine. It won't take you anywhere and your bum will go off. And what I mean by that is like the engine alone doesn't do anything. Average clinician spends like 4,000 clicks of the mouse in a single shift. It's a huge amount of friction that's not really accounted for. We're trying an A&E at the moment. Actually, I think it might turn out to be the strongest use case. Anecdotally, we're seeing like big increases, maybe even doubling the number of patients seen per shift. That's a turnaround time 0, right? Go back 20,000 years, right, to the shaman or whatever we had, where one person was wisdom. They held the arcane knowledge. Now, knowledge is distributed. And we had Dr. Google, now we've got Dr. ChatGPT, but you could almost argue in many senses, sometimes Dr. ChatGPT is going to be better than the doctor. And that world will come really, really, really soon.
Hi, everyone. So today I'm sitting with Dr. Dom Pimentoa, a practicing cardiologist, but also CEO and co-founder of Tortus AI. He is genuinely one of the most interesting people working at the intersection of AI and the NHS right now. We get into everything: why most NHS innovations often miss the mark, how to build an AI product that doctors actually want to use, and some pretty bold predictions about where healthcare is heading. He doesn't hold back, and I loved every minute of this conversation. So please enjoy. Let's get into it. Hi, Dom. Welcome to Inside Health Innovation Podcast.
Hello, thanks for having me.
Yeah, thank you so much for joining us today. I'm really looking forward to discussing AI with you as the resident expert going around all the circles at the moment in the NHS talking about AI.
That sounds like a good or a bad thing, I'm not sure.
I can't wait to hear more about all of the work that you're doing at Tortus as well. But I'd like to start by asking you what may come across as a simple question, but can be different in every person I speak to has a very different take on it. And I'd really love to hear what you think of when you think of the word innovation.
It's quite funny, isn't it? So like, my first instinct is, wait, hold on, can we swear on this podcast?
You can swear as much as you like.
Right. So my actual thought, if I'm being super honest, is bullshit. And the reason is that you're spending 16 years in the NHS and you look at the innovation departments and like, as an on-jobbing doctor, it's rare that you see an innovation that you think, oh, that's useful to me. So then I thought, well, why is that my first instinct? Well, I've seen a lot of stuff that doesn't work because it doesn't solve my problem.
Yeah.
So I think innovation is about solving a real problem in a new way. But I think it has to be that way around. And I think there's too much time we think, what's new and what can we do with it? I don't think that is actually innovation. I think innovation is about solving the problem.
Yeah.
And sometimes, solving the problem means doing old school things.
Yeah.
And we see that a lot in the AI space. Like, sometimes it's actually a better idea to not use the latest model, but to use a simpler, much older version because it solves the problem of reliability or robustness or something like that. So, yeah, probably get in trouble for that first statement.
So what you're saying is it's not so much about just sort of going forward with whatever's the latest trend or new tech, but just sort of almost having you're laser focused on solving the problem.
Yes.
As opposed to just, talking about whatever the latest trend. And interestingly, I guess everybody's talking about AI right now. And I'm curious to hear what you think of when you think everybody in health tech is embracing AI and whether that is indeed solving the right problems.
Yeah, again, super interesting question. I think AI as a technology is not actually that new. It's not even, people were talking about the neural network about 25, 30, 40 years ago.
Wow.
But it has taken a while to get to the point where specifically large language models, so that's really been the sea change, have been powerful enough and useful enough to mean something. So I first came across GPT-3 as it was then, so 2.5 years ago. And before that, I'd sort of done a little bit of natural language processing, so looking at words and text in medicine. And as you all know, medicine is language. I mean, at a fundamental basis, it's like 95% is like chit chat, and then you write it down. And within that, there's decision making, there's diagnostics, there's MDTs, and then 5% is people get cut, and that's surgery. My wife hates that joke.
I'm not sure. When you first said it, I was like, what? People get cut?
Yeah, that's the reality, isn't it? Chatting and cutting is medicine as a whole. So
chatting and cutting.
The language is so what the sea change is you have technologies that can unlock language, and medicine is language. Therefore, suddenly the computer in the room could understand what's happening in the room. So it opens up all these black boxes, all this data, all this productivity. So I remember meeting, anthropomorphized the model there, using GPT-3 for the first time. And I asked it, what is heart failure? So background cardiologist, I was like looking at new models, and that's my opening question to any time I come into contact with, I'm trying not to say meet now, a new model.
Yeah.
And I was blown away because I was like, well, here's all this clinical knowledge. It wasn't just regurgitating things. I could ask questions, I could ask to explain. I thought, wow, this would be great for patients initially. It's like the one thing that we're terrible at already is like translating into layperson language all of the, medical terms or the drugs or the why of why they need to take these medications or do that treatment regimen. So I actually do think it is a transformative technology, but again, to go to my first point, it's just a product. It's just leverage, right? So I can't remember who said, I think Steve Jobs said, like, computers are bicycles for the mind. And I think about large language models specifically as like a combustion engine. Another terrible dad joke. Like, don't sit on a combustion engine. It won't take you anywhere and your bum will get hot. And what I mean by that is like the engine alone doesn't do anything.
Yeah.
It doesn't solve the problem. And in healthcare also, it might solve the problem, but it doesn't do it in a safe, reproducible, robust way. So you have to like build the entire vehicle around it.
Yeah.
But too many discussions already in the space because it's hyped and there's a big trend.
Yeah.
Think, AI is the answer. When actually it's like, okay, what product can you now build that you couldn't build before? It was too slow to build or too expensive to build that solves the problem. And I think that's really interesting because now, we've relied on humans to do almost all of the data work. And I mean like data entry into systems of your documentation, clinical coding, audits, the retrospective billions of man hours a year in the NHS spent on audit. These are all data tasks. And we just say, clinicians do it because it's helpful, they've got some time. Truth is, they don't have any time.
Well, certainly not now.
Yeah, but we didn't have an alternative, and now we do. And I think, again, how do you solve a problem in a new way? Well, new technology often does that, but not to confuse it. It's the problem first, and then, whatever technology.
Well, no, that makes a lot of sense. So talk to us about your journey into AI and entrepreneurship. So, as you said, you've been a doctor. You've also done varied other sort of roles, pharmaceutical physician and so on and so forth. When you think back to your early years, when you were studying medicine or first few years into training, did you always know that you were going to go beyond medicine and do something else?
Yeah, it's super interesting because I don't think I am beyond medicine even now. I still practice as a doctor, right? So so if you go back to my early years, when I was 4, no, I'm joking, but I'm not really joking, I decided I wanted to be a doctor. And I can't remember why. And to this day, I don't know why. So here I am as a doctor. I know, but more interestingly, like my entrepreneurial spirit is like, make a plan, execute the plan until proven otherwise. Right. And then that never happened, right? Went to school, went to uni, became a doctor, just went through that railway.
Yeah.
So I think my journey was, went to UCL, qualified, practiced mostly as a cardiologist up until around 2019. The railway started to get a bit shaky when I went through all the subspecialties of cardiology. Right. And I kind of liked all of them, but I didn't love any of them. And that's quite bad because you have to pick a subspecialty and you have to do that for another 35 years.
Right.
And I was like, So my actual plan, which is not the best plan I've ever had ever, was go and do a PhD, forget about this problem for 4 years and come back. So my first sort of inclination of, maybe I should do something in AI was that thesis, what's interesting to do. This was like end of 2019. So learned to code, did a bunch of courses on Coursera, started applying for funding, got a very mean rejection from Imperial. Said, unserious about AI. And I was like, I'll show you.
What? Hold on. Why did they say that?
I don't know. It was the meanest rejection email I've ever received. Response. But like, I feel, you've seen, what's that Michael Jordan documentary? What's it called? Oh, it's great.
Oh, yeah, I know. First something, isn't it? I can't remember what it's called. I know the one you mean, though.
Yeah, but he always goes on about how if someone wrongs you, and he used to just imagine that people had wronged him after a while just to get that motivation. But that definitely is one of my motivations. I'll show you one soon. But that was like, early 2020, applying for AI funding, and then suddenly everything dries up because COVID comes.
Yeah.
So then I got redeployed to COVID ITU as one of the first wave of doctors to go there. And like, tertiary cardiologists are going to intensive care actually isn't a big jump for us. Massive jump for the nurses, by the way. Right. Just shout out to the nurses. You do your cardiology ward job and then suddenly you're managing 5 machines like a week later. Wow. That's an insane... We didn't talk about that bit enough, but anyway. So I was doing that. And then as part of that, I sort of got the bug because ended up side co-founding a charity. So I think that was like my first, COVID disrupted everything, disrupted my life plan, but also disrupted what was needed. There was suddenly a terrible need for PPE, made like loads of mistakes, talk about founder mistakes as a textbook case study. So 5 co-founders, mistake. The 5 co-founders were me, my wife, my sister, my wife's cousin, and one of our best mates.
I'm surprised not one of your kids in there.
Well, almost, but they were probably too little at the time. And, hired amazing talent because everyone was working at home. They just wanted to help. Didn't recognize how great that talent was because I thought, this is just people in the world. But like, just for a flavor of that, the head of social at the time now works with Coca-Cola. The head of comms is like world lead for Procter & Gamble.
Amazing.
The head of brand just represented Guinness. Like, it's crazy talent.
Yeah.
The chair is now one away from being the chair of the London Stock Exchange.
Wow.
So like, but yeah, I thought this is just normal, right? This is just business land. I don't know. As a doctor, right? I have no idea. But actually what was really interesting was that itch that I had for continuous intellectual stimulation wasn't being scratched in cardiology land. And I think that was my first hold on, where does this go?
Yeah.
Right, I've got to the end of this road and it doesn't go where I wanted to go. Whereas founding was like, okay, go and set up a charity, figure out charity governance. And then the next day, have an actual fight with the BSI about why they don't need... what was it? They wanted something very specific about masks in hospitals because all the standards are built for factories.
Right.
So like, can it withstand 300 degrees of heat? And I was like, no, it can't. And if that happens in an ITU, it will explode. So what are you talking about? And they went
Why
back
do you
and
even
forth.
need it?
But they were like, we don't understand the question. Like, we're the BSI, right? These are the standards. But like that continuous, like, how do I do this? And how do I do salaries? And how do I run a team? And even today, like, that's the bit that I love the most about founding. Every level above, you have to learn something new. You have to figure out something else.
Yeah.
You have to revisit all the mistakes that you've just made and be like, screwed that up.
Yeah.
So did that for 6 months and then basically I did 4 days in ITU, 3 days in running the charity as a CEO. Wow. And it was really interesting because in those days you couldn't take your phone into ITU, right? If you remember, we weren't allowed to touch it. So I was basically completely out of the game for 4 days a week. So I basically go away and do nothing. And then come back and cause absolute chaos in the charity, like make new partnerships or make an announcement or do something else, and then run away again and let everyone else tidy up. So like, there was a lot of like seesawing.
Yeah.
But it was very like fulfilling.
Yeah.
I think action, lots of founders talk about this, but action is an incredible way of, I think Jeff Bezos was saying this exact thing on LinkedIn recently, was his anxiety decreases as soon as he's taken an action about something.
Yes.
And this was like this writ large, right? Everyone's super anxious about COVID. What does it mean? we're working at the front line. First 4 or 5 weeks, super rough, like lots of mortality. But actually, then you're doing something meaningful.
Yeah.
And I think that was the counterbalance, and just general counterbalance to life. If you have purpose, quite like robust in terms of what else happened. But obviously, after 6 months of that, I was pretty like burnt out, so I quit. Went into pharmaceutical medicine. So I worked at what's it called, a clinical research organization.
Right.
Worked on silencing RNA and gene editing, and it was quite an interesting experience because I was nearly a consultant cardiologist. At ST6, I left that, so I had quite a lot of like experience.
Yeah.
So running first in human trials of quite sick patients with cardiac amyloid was actually awesome, and controversially, got promoted for good work. Can you believe it? Right? I was like, what is this? Why are you promoting me? I was like, well, you've done some good work. I was like, what does this mean? I don't understand. Because no one in the NHS understands that, do they? Like, you just,
I've spent 10 years on the front line of the NHS, not clinical, but I know exactly what you mean.
Exactly.
There's a reason I'm not in it anymore.
So I was doing that for a while, and then the personal circumstances meant I had to sort of switch from going into the office and giving drugs to working from home. So I became an AI academic. And I learned to code and do machine learning and basically dusted off that PhD. And I ran the academic arm of the same CRO for a couple of years, and I did digital health in liver disease and heart failure. Super good trials. To go to your point, though, liver disease, very high AI, almost absolutely no point. So, like, to give you what that means is like we were trying to develop an algorithm to detect if someone has fatty liver disease. Right. Super useful in pharma land because you get weird drug reactions if you can't find it in patients. Built the algorithm, had amazing discriminatory capabilities, so we could pick these people out really well. But when we boiled it down to why the model was so good, it basically looked at, what did it look at? It looked at BMI and age. And you can see that with your eyes. Yeah. So you don't need a computer or AI. And the whole thing was completely pointless. Yeah. It was just one of those like academic exercises. Whereas the heart failure one had no AI in at all. We just had scales at people's homes, and they would stand on them every day. But the tech was they were connected to the cellular network.
Right.
So we would get their weights on a daily basis onto an Excel spreadsheet, and I could see 400 patients' daily weights. And I would just call the segment that had increased their weight for 2 days in a row. We'd be like, what happened? And sometimes like, my wife stood on the scales. That was quite common, actually. Because then it like
that I was not expecting.
Yeah, right. Like it drops down and comes up again. But most of the time they were like, my GP stopped my drugs, and then I just start them again. And then actually we kept like 80% of patients at the hospital. Wow. So it's massively powerful and not innovative at all, but actually just the way that you've done it and the way that you've changed the model of care. Yeah. But then couldn't publish it. I was like, academic's too frustrating. Like, just go and do this. Like, this is a life-saving thing. So sort of came to the idea that going to an accelerator and trying to found something again, but for this space, like in a real way, was for me. And I kind of had some chops to do that. So got into Entrepreneur First, which I think you've had some guests on.
Yes.
And it's a great shop, and it's a really interesting model. And when it started, very controversial that they're investing not in companies like most accelerators, but before that, in people who have talent but maybe don't know what they want to build or want to ideate, and they foster that ecosystem. But I think the one thing that it does, like I was just with Matt Clifford just now, actually, it just injects into your eyeballs, which you really need to start a company in this country, is ambition. Yes. Because they're like, you're going to build $1 billion company. And they just say it to you every day for like 8 weeks. And by the end of it, you're like, I'm going to build $1 trillion company. Like, you're really like, you really drink the Kool-Aid. But if you don't, then it's too hard. And you think you're going to fail because everything becomes insurmountable. Whereas actually that mindset is actually being...
Is it run by... You can guess why I asked this question. Is it run by Americans?
No.
It is. Who runs it?
So Matt Clifford and Alice Tink are the co-founders. I think it's wrong now, about 10 years ago. And they've just built a UK ecosystem. It's almost entirely, UK founders, and increasingly now, people who have been founders or were operators are part of the wider ecosystem. So, for example, Rob Bishop is one of our advisors now, but he was one of their first cohort. He founded a company called Magic Pony, like 22, sold it to Twitter at 180 million.
Amazing.
Like, didn't really leave the biscuit factory in Bermondsey or whatever during that whole period. So, like, I think the import there is the American attitude to it.
Yes. Well, that's why I asked,
But I think it's interesting because it's just a mindset shift.
Yeah.
They actually now got offices in San Francisco. They've got an office in New York. But it's just like, okay, you're going to found a company. We're going to give you the resource. We're going to give you the network. Super important. Like the way that, we raised money was essentially through network, and that was through another founder that was in the cohort before. Right. So that takes time to build, but they've done a really good job at that as well. And then it's just, what is it that British founders need? They just need ambition. We have the universities, we have the skill sets, we have the companies now as well. Google's here, Meta's here, Pimenta's here. Like, these are top places. But often it's I should say this, but like, so there's a really good sketch exactly like encapsulating this of like a UK comedian who goes to the US. I can't remember his name, but he's really funny. And he says, I love it in America because every time you talk to anyone, I'm going to build $1 trillion company. They're like, yeah, man, you do it. Let's go. I'll join. Let's go. Like, it's a complete reaction.
That's true.
And when he comes back here and he goes, I'm going to build $1 trillion company, his mates are like, don't be a dick. Do you know what I mean?
Well, it's so true, isn't it? Like,
I literally had a mate who said that to me. Don't be a dick. I was like, it's true.
That kind of very open ambition is not really looked upon kindly. And I don't know if that's just the British culture. You know, there is a bit of sort of, tight-lippedness, as we all know, in the British culture. And I was born in India. So first 15 years of my life, I was in India. And I think there is a slight different culture there where we were really encouraged to be really like, I am going to do something amazing. And I remember when I first moved here and I was very like, I'm going to do this. I never said I'd build $1 trillion company. I haven't said that yet. But I was looked upon, in a funny way and sort of dubbed as arrogant, etc.
Yeah, exactly. Are you mad? Are you greedy?
Exactly.
Are you arrogant?
Yeah.
It's like, maybe to all of those. But like the point really is like if you want to have, and I think that Matt Clifford talked a lot about this, like it's actually easier from a logical perspective to be overly ambitious than it is to be underly ambitious. Because if you're aiming for middle of the road, you often end, 25% of the way there. Exactly, right? But if you're aiming for that 10,000% outcome, 100, 200% of where you started seems very doable.
Yeah.
And it is just a mindset shift, but it does make you, constantly take the moonshots.
Yeah.
I say this to my team all the time. Like the idea of taking a moonshot sounds crazy, but we did it. People landed on the moon. So like that makes sense. But you only have to land one and then you're on the moon.
Yeah.
So you can take 100 and as long as it doesn't, kill you to do that. So again, sometimes it's just about doing stuff.
Yeah.
What's that thing? 95% of every obstacle is just in your brain.
Yeah.
And there's 5% of like physics.
Yeah.
Like whatever's actually like, the laws of the universe.
Yeah. But I guess, so people perhaps who've been on programs like that with that kind of support, might sort of find that ambition because I think it exists, right? Like some people have it, some people don't have it, and it just needs surfacing perhaps. But people who don't get to be part of such a program, where can they start? Where can they find that kind of, do you know what? I've seen a problem. I'm not just going to moan about it because that's what most people do, right? Like, this is rubbish. And, I was a director of ops in the NHS for 10 years.
Respect.
Eventually, I got to the point where I was like, I can't deal with this anymore. And I therefore went out and did my own thing. But, it took a lot to quit and take on something new. So I guess, what do you think helps people take that step forward, if not ambition? Because that, as we discussed, is not easily
I think
available.
It's a good question. I think actually, I'll roll back on that a little bit. Like, it's more important. For example, if I didn't like what I do now, I would have quit a long time ago. It's so hard, right? It's 16-hour days every single day.
Yeah.
Wake up in the morning answering emails. I'm up at 10 answering emails. And the reason I love it is because I love it, right? I'm actually having impact. Yeah. We can now see physically, saving time, improving patient care. I think patients really like it. Like it's deployed in real hospitals. Yeah. The rewards, it's like a really rewarding time for us because we're actually getting to the deployment stage. So like, what I'd say generally is, what's that? I'm going to probably quote Paul Graham all the way through this, but action is information, right? So like, you might think you want to start a company in X. Go and start it and see what happens. Like, do you love the problem? What's that? That's another book, Yuri Levine. Fall in love with the problem and not the solution, right? Like, if you try something and you fail, and you almost will definitely fail the first time you try anything because you'll realize you built the wrong thing or the customer doesn't exist or blah, blah, blah. If you don't go, that's great, I know that doesn't work anymore, then actually that wasn't for you. And it's better, I think, people spend a lot of time thinking that they want to do something and never trying it. And that, I think, is one of the most dangerous states of humankind, because basically what you're doing is you're waiting for your life to begin, but you haven't figured out how to eliminate that is a good idea. That's something interesting. We were interviewing someone ages ago. I didn't actually manage to employ him, but we were doing this interview and he really impressed me. And I said, how did you solve that difficult business problem at your last company? Expecting him to say, we strategized. It's like, no, brainstormed all the ideas, respected that we had no idea which of these would work, and we aimed to take some off the table as fast as possible. So all they did was like get rid of the wrong ideas as quick as possible.
Yeah.
So again, like, you know, do you want to start a company? Yeah. Are you going to be good at it? You don't know. No one knows. No. I didn't know I don't know if I am good at it, to be honest. The jury's still out. But like, what you will find out very quickly is it for you and do you love it?
Yeah.
And if it is that, then you found something that you can pursue infinitely. And then you know, the problem that you're solving will change and the people that you work with might change. But that philosophy of just start.
Yeah.
So like, you know, for example, when I decided that large language models might be good for patients, I was like, why don't we test this? So I started coding it in Python. I didn't know how to build an app, but even like playing with it and using it in Python, I could demo it to people.
Yeah.
And people are like, I get what you're trying to build now. And actually, that's really cool. Like the AI is interacting. And they completely forgot that the whole thing was just like MS-DOS style, if that means anything to you.
Like just a bit.
Yeah, exactly.
Just a bit.
It's just like black and white screen.
Yeah, I know what you mean.
But like that was all it is. But actually the simplicity of it, but also the fact it actually worked. Okay, this is doable. I can build this. And then you can put money and effort behind it.
Yeah.
So I think it's not even about like, do you think you can get there? It's about, okay, holding that state in your mind, but also recognizing that it's going to be fun to fall over many times on the way there.
Well, yeah, no, absolutely. And I'm sure I had, and I'm sure some entrepreneurs say to me about how, you know, if you're not embarrassed by your first MVP, you've gone too far.
Yeah.
So it's the same thing as your MS-DOS thing, where, you know, if you're building something, you want to get it out there as quickly as possible to get that feedback, so you can actually build something that's useful eventually, but get it out sooner rather than later. So the whole action is information kind of thing. So talk to me about. So you said you're also doing some clinical work, but of course, you know, I imagine. The amount of clinical work you get to do now is
little now, like one shift a month if I'm lucky.
Yeah. How is that transition? So obviously you talked about how much you love being an entrepreneur or solving problems in the way you are. How do you feel about moving away from that direct patient care?
Yeah, I think because I worked in pharma for a bit, so I had a bunch of patient cohort, but even that was a bit removed.
Yeah.
So I think a couple of things. I think it's a tremendous privilege to. And also medicine is a very pure endeavor. And what I mean by that is you see a patient, they have a need, you apply your brain, you help them, they go home, or they don't sometimes, but you tried, and then that's it. And I think, especially in hospital medicine, where, you know, that's where I was born and raised, so I didn't get that continuity of care. But there's no bullshit. There is a lot of politics, but not at that level. And I think that's the bit that I hated about medicine and climbing the career ladder and things. It's very political and it really shouldn't be.
Yeah.
But it's extremely rewarding. And I think the other thing that it gives you is perspective in a way that you don't get in most parts of life. So what I mean by that is, you know, the other day it taught us, everything was on fire and there was a disaster everywhere. And then I was just like, well, no one's actually dying. Right. And that was my job. I was the heart attack centre registrar for about 3 years at the Royal Free and at Barts. And like, people come in there, cardiac arrest, they're on ECMO, they're at death's door, and you're going to make decisions then. And that's stressful because if you make the wrong decision, they will die and their family is screaming in the corner. That's stress. Yeah. This is just fun time, right? Like, honestly, I think that perspective is great because you can scale that. You know, however bad the fire is, you know, however important whoever it is that you're pissed off is, which just seems to getting more and more increasing. It doesn't really matter. Like, are you solving the problem? You're doing the right thing, and you can just crack on. But that's the bit I think I miss more than anything. Is like that grounding of whatever you're doing. And it's interesting. I've spoken to quite a few physician founders. The very, very, very best ones still practice. Yes. And it's almost exactly for this reason.
Yeah.
You have to stay grounded. You have to understand. You can't lose. I also say this a lot to clinician entrepreneurs, like, don't come out too early. Build your skill set, build that muscle, enjoy the privilege, if nothing else. I mean, it is a hard job. It has got harder because of a lot of other reasons, but so there's, to look after someone, to help them, it's not actually something that a lot of humans get to experience.
Yeah, it's a very noble profession.
It's just soul rewarding. If you want to talk about it in a selfish way, like it is something that's good for your soul, and there isn't that many things. So trying to spend more time, actually like now trying to like actually move around and do shifts places where Tortus is live, because then I can do a bit of like sneaky customer day. I'd also say this, like, it's a weird thing to say, right? So I haven't used Tortus much clinically because it's not been live where I've been working in data and stuff. I did use it clinically for like the first time properly in an actual clinical situation, because I also do a bit of like chief med officer role at Tortus. So when people are sick, they come to me and I sort of refer them on and stuff. And I used Tortus to do a consultation.
Right.
And it was so interesting because I looked at the output in a completely different way. I looked at it as our actual users look at it. It's like, okay, these are the notes I'm going to write to the judge, as you would if you'd written them yourself, which is a very different mindset. And that was incredibly useful. I was like, I can't wait to go, like, St. George's A&E right now. I'm trying to get in there and be like, because they're using it. Like, try and get in there and like just use it and see how that works. Because I think that's the mindset. So it's like you can combine some of the worlds together.
I really like what you've said about, the groundedness that being a clinician brings you. Do you feel like in health tech, therefore, clinicians make better founders?
It's a super good question. I think there's a yes and a no answer to that, and I'll come back to the no answer. The yes answer is the skills are actually very transferable. So I remember when I first got into the accelerator, right, I really sucked at pitching. And I remember like a real heart-sink moment, like one of my very earliest, like, I'm so rubbish at this. Pitch to an audience, good 2-minute pitch. First hand, first question. Yeah, but what is it?
Oh dear.
It's like brutal, right? Like grim as. So I was like, oh God, what have I done here? And I thought, oh, hold on. Complex ideas to lay people, which is actually, if you take the AI apart and actually what you're trying to do, how to do that. Taught how to do that. You're going to signpost. You're going to break it down. You're going to check their understanding. So okay, I can actually use a lot of the skills I already have to start applying. And, things like context switching. Have you ever done a med-red shift? That is context switching.
Right.
To the nth degree, 50 patients, bleep going, nurse coming over, SHO's gone missing, like all sorts of nonsense. You just have to get to the end of the shift. So, I'm really happy to work, long hours, night shifts, a lot of the brutalness of it is actually not very far removed from hospital medicine. Consuming, it's one of the things I've approached being a founder is laughing the other day because my wife's like, you keep buying books. And I was like, yeah, you read the book and then you do the thing. That's life, right? And she's like, no, that's medicine. That's what you do in medicine. You start a new specialty, you read the book, and then you go and stick a wire in someone's heart or whatever you're supposed to be doing. And that sort of see one, do one, teach one mentality is really actually quite weird. Once you've done it a few times and you have confidence that you can learn and apply your skill and you're not going to make mistakes because you have absorbed the knowledge in the right way and you've got that muscle memory, super useful in founding. Go learn how to write a financial model, which I still can't really do, but just trying to learn. And then just do it. And I think that is, I know it's talking, you learn to talk to anyone, right? And I think that's another privilege is the spectrum of humanity, or just maybe the sheer number of people you meet. Anyone who faces customers, there is a privilege there, whether customers or patients being more real, so more of a privilege. But you meet people from all walks of life every single day, far more than the average person does. That gives you I meet people all the time. I met you. I know your energy. I know what you think because I've met you 3 or 4 times before. So I think that, confidence in any room is also very helpful. Now, why it's not a good idea is actually basically the corollary of all of these things. So doctors, this is controversial things. It's an interesting podcast. So doctors specifically often have that, you really, there's no other way to say this really, lack humility. And what I mean by that is not in a mean way. It's literally you're used to walking into a room and being, the oracle, being the source of knowledge, the expert. and expecting people to listen to you. And the second corollary of that is you're raised in a very hierarchical system where you're in that room until your boss walks in and then it's their voice and your voice transfers instantly, and that's how authority is, that's how it works.
Yeah.
Actually, like that doesn't transfer well at all, especially into tech, especially with like slightly younger employees. Their expectations of how life is very different. Fostering autonomy means letting people make mistakes.
Yeah.
Do not let people make mistakes. If I go and help my junior doctor on the ward, they're super helpful. Oh, the reg is helping me. What a nice reg. I go and help my junior dev. They're like, why is the CEO coming over and interfering? And it's like that. Yeah. So that mentality, that mindset shift is really tricky. And I think the other thing is people come out too early. And I see it all the time. And actually, you know, I'm a doctor and I haven't even practiced. I was like, well, actually, you've got a science degree. And I think maybe, you know, what is it? What is being a doctor? What is being a clinician? It's absorbing knowledge, making decisions and taking responsibility for those decisions with real human lives. That's the bit that you're learning.
Yeah.
So if you haven't got to that point, then your value add to any health tech or founding or company actually diminishes over time. And if you can't rapidly upskill in product or tech or CEOing or whatever the skill set is, then you just get stuck in limbo land. And you're sort of, you know, a doctor that can't remember anything or never learned anything, and a sort of mediocre person who's still learning how to do the other side. And it's really hard to put those two things together. Yeah. So I think, still keep practicing. And that also keeps you humble because you start being like, oh, shit, I forgot this, like, and ask for help. Yeah. Like, I do that all the time when I'm in the clinical.
Yeah. No, I think that makes perfect sense. So you talked about Entrepreneur Fest, and you described, obviously, the program. So I understand you also met your co-founder through the program. How did that sort of matchmaking take place?
So previous co-founder, Chris, machine learning engineer, mathematician. So the way that Entrepreneur First worked, which again is one of the uniqueness, and I think one of the great things about the program, is you don't know anyone on the cohort. Yeah. Right? Everybody's new. Yeah. So in that sense, it is literally, I've described this before and I got in trouble for it, but it's like Love Island for tech nerds, right?
You know, someone else has described it.
I think they stole it from me, actually. I think that's okay. Because I think I stole it from someone else, actually, thinking about that. Anyway, it's, you know, art is theft, right? So it's exactly like that. Like you come in as singles, you have to couple up. Yeah. So it's interesting. I didn't meet Chris until way into the cohort. I was with another co-founder before, and then we were building stuff and we had customers and we were building like a pharma thing. Right. And he was like, I don't like healthcare. I was like, well, I'm not really going to be able to do anything else. So maybe we should diverge here. And I remember like pitching to another co-founder and he was like, well, I'm not interested. And also being quite rude, like on his phone and stuff. And I was like, we should build this thing. So nice. But Chris leaned over and he was like super interested. And I was like, so actually, and then we started building together. He was building action models and computer control systems. I was really interested in clinical large language models. We thought if you put these two things together, like language and action, we can build over the top of electronic healthcare record systems, which was our initial product thesis. And we did manage to do that in a week. And this is one of the tests, like you sort of pair up and it's like, well, how much and how fast can you build something to get to my point about just build something in a week that de-risks your strategy. So the first de-risk was, is it technically possible? And then there's like regulatory risk. So technically we built something that I could see a patient end to end, summarize the information, listen to the conversation, document that conversation, write the medical note, order the chest x-ray and close the encounter and save it without touching the computer. It was all automated. Brilliant. Spend the whole time with the patient.
Sorry, you built this in a week?
In a week.
Amazing.
Right, combination of AI models, super crude. It would break if you basically blew on it. So it was super like brittle, but it worked. And it proved out that A, it was a great experience for both clinician and patient. B, it was technically possible. And C, it saved a whole bunch of time. Yeah. So it was like, okay, this is a really strong thesis to build. And then we got super excited around AI controlling computers and really didn't stop to think about where the balance of value actually was. And it was very much actually in the tools as opposed to how the tools interacted with the computer, which did solve a problem on day one. Is like, it's really hard to build integrations to computers. But 2 years down the line, when you've got integrations into Epic and a bunch of other EHR systems, the value add then of controlling the computer diminishes quite substantially. Whereas the tools and the safety and the deployment, the robustness, and like ambient, for example, being a really good example of that, are very much more valuable in that sense. So we sort of, continue from there, raise some money. And
here you are.
Here we are.
So tell us what Tortus AI does as of today.
So as of today,
Sure.
Or gin, whatever.
Could have got you some gin, had you?
No, I would not have made sense.
We'll put it in the feedback form.
That's the thing about founding. You don't drink. I do drink like normally, but there's no time. And I've founding in 3 kids. There's no meeting that's worth it, or looking after the kids that's worth the hangover.
Indeed,
so basically, just don't drink alcohol, which is anyway. So what does Tortus AI do today? So the idea is it's an interface between the computer, where clinicians spend 60% time, very high friction. Average clinician spends like 4,000 clicks of the mouse in a single shift. It's a huge amount of friction that's not really accounted for. So moment of national crisis, global crisis in terms of healthcare workforce, and we're wasting about half the time. So the idea is we combine a bunch of AI models to basically be the interface between the clinician and the computer. They can go much faster and do much more things. So today we've got speech-to-text models, so listens to consultations, creates transcripts, converts that with a large language model or a series of large language models into their medical notes, which is sort of customized for their style and their structure, which is super important for adoption. Clinical coding, downstream documentation, like letters and referral letters and things like that. And then coming very soon, looking at clinical decision support, deeper integrations, summarizing the record before the patient, and then doing the tasks post. So if you look at that 60%, it kind of buckets up as about 30% of documentation time, about 15% looking up stuff time, and about 15% doing stuff time, so prescribing referrals. So the idea is we take that 60%, we shrink it down to less than 15, and then you go from 40% with patients to 85%. So you're over doubling your patient-facing time. Been running a bunch of trials across London and sort of scaling up into the commercial, but about 5 minutes saved per new patient in secondary care. So you could easily see one extra patient, £500 for the clinic, sort of the ROI comes back 50, 100 times. In primary care, the use case is much more around quality of life. Although this is big time savings, about 4 minutes saved on a 12-minute appointment. Some really good data from one of our users who's used it about 6,000 times in the last year, like the longitudinal data. But he goes home early, he's much happier at work, much more energy. Therefore, it becomes a much more sustainable career. And then it's about churn and absence and how much full-time equivalent working are we getting from existing workforce. Because the work is easier and it's less cognitive load and it's not as demoralizing. And sort of live in going up to 8 hospitals now, and about 100 primary care clinics, do about 15,000 consultations a month, about 1,500 a day.
That's amazing. And what's the feedback you're getting from secondary care?
It depends. So we've got some outpatient work. Generally, people love it. It's interesting because all tech adoption has a curve of your mega adopters that love it and they use it all the time. And then your distrusters who's like, what is this? We had one on that scale. We had one user who distrusted it so much that they still typed during the consult while we were doing the studies. I was like, well, what's the point? You're not even using it. It's just running in the corner.
Double working.
I'm just curious what it does. I was like, okay. But at the top end, like you saw 60% increases in direct care, like 25% reduction in time spent, better turnaround time, 0, right? In fact, one of the most interesting, like unexpected effects was because the letter comes out when the patient's still there, asking the patient to check the letter before it gets posted to the patient. It's crazy. So generally people really think some demand, and it's really nice to see there's one hospital that we're working with that like they're getting there but to roll out. But occasionally I get CC'd into emails from their consultants going, where is this thing? We want this thing. We tried it and you haven't got it rolled out yet. So the demand is great. We're trying an A&E at the moment. Actually, I think it might turn out to be the strongest use case. Because there it's all about throughput. They're not so, what's the nice way of putting this, fussy about their documentation. They just need to get it done because there's so many waiting. So like anecdotally, we're seeing like big increases, maybe even doubling of number of patients seen per shift. And then if you can imagine what would happen to your wait times, your 4-hour wait targets, if that was like dropping like a stone. So it's just remarkable how much of a pain point it is to then solve it. But to go back to my initial point about innovation, like it's such an obvious problem.
It does feel like it. I was just going to say, I feel like it was at least 4 years ago when there was an article about how many clicks doctors have to do in their sort of day job. And it's interesting that, you know, because like you said, so perhaps large language models, etc., generative AI is newer, but it's not like some kind of automation didn't exist 4 or 5 years ago. But like you said, it almost feels obvious to do it, but nobody's done it.
I think just, if I'm really honest with you, the technology to do it properly has only really existed for maybe 6 months.
Yeah. Okay.
And actually, you know, that's not just speech-to-text models or, you know, a bridge is one of our biggest competitors. They've been around for about 4 or 5 years.
Right.
And they were doing this, but not at this kind of scale. Now they're doing really big scale. But latency. So even the stack that we have to do half an hour of audio took 15 minutes to process 2 years ago.
Right.
So really, actually, in the clinical workflow, I mean, forget primary care, no chance, right? And even in secondary care, half an hour with 15 minutes between, you just write it up yourself, right? Now, half an hour takes 5 seconds.
Amazing.
Right? Yeah. So like that becomes unlocked, and it unlocks primary care as a use case. Same thing with the large language models. Used to be a 90-second turnaround time about a year ago. Now it's about 9.
Yeah.
And the quality goes up, and the metrics and the evaluation and the monitoring is all improving. So it's one of those things that, you know, when we talk about innovation, okay, the problem could only be solved in a certain way, but now it can be solved in a much better way.
Yeah.
And then it's just about rapid adoption, because that switchover then becomes an inevitability. But I also think it's fascinating that once you've changed the workflow, so every conversation flows through a large language model, scribing and like coding and letter documentation and anything focused on the clinician is just one possible output. But there are like 99 others, right? The system data, the data that you can have access to, the black box becomes, you know, somebody on the 11th floor of the hospital can see what people are talking about in A&E.
Right now,
Right now, right?
Exactly.
Pandemic symptoms or norovirus or, you know, imagine like which antimicrobials are we prescribing? Classic problem, every hospital, every year.
Right.
Nobody knows. Everyone does an audit. Everyone instigates it. Flu season's over. Everyone's forgotten about it. And then you just do the cycle over again. But what if you could not only monitor which antibiotics are being prescribed, which doctors are repeatedly off book, and actually just give them a gentle nudge. Like, no, we're not doing clarithromycin this week. We're doing metronidazole, please. Thank you. And you swing the switch. I mean, if you're an antimicrobial person, that's probably a terrible switch. But like, you know, it shows how long I've been out clinical. But I think my point really is like the data unlock and the system change that we'll now see. I think we've even really imagined.
And the speed with which you can share that information and data.
Well, live.
Exactly. And you know, somebody said to me, the NHS is really yes, it's healthcare, but it's a business of communication.
Yes.
Like all healthcare, and you were saying the same thing, isn't it? So it's all medicine is all about language. It is quite a big deal to be able to share that information about a patient live between floors and departments that need to process them in different ways, because that's where the productivity and efficiency might come from.
Exactly,
yeah. No, brilliant. So, Dom, you talked about LLMs, which inform the workflow within Tortus. So it sort of helps them transcribe the conversation the clinician is having. Where do these LLMs come from? I assume it's not just on top of ChatGPT. So have you built these from the ground up?
No, I mean, so the system is, there's quite a few different components in terms of the models. I think when we first started, there was a conversation to be had about, were we going to train our own foundation model, or are we going to use stuff off the shelf? So third parties, APIs, OpenAI, or Anthropic now, and Google, and a bunch of open source models as well. And I think our initial hunch was actually the right one, was that we would take too long to accumulate the data to be able to keep up with the generalizable models. There's this concept in AI called the bitter lesson, and most things just get better over time with increasing amounts of data. And you know, the data that O1 is being trained on is like the entirety of the internet.
Right.
So startup, we can't hope to compete. But actually, interestingly, we also then said, well, if we are going to create a system where we're going to constantly swap out models, how do we know that it's improving?
Yeah.
So we had to invent that. So then we ended up building an AI system around it. So basically, the first thing we said, okay, let's look at the task. And this is a really important concept in AI. The evaluation becomes almost more important and harder work than the technology that you're using.
Right.
Because then you build a system which is guardrailed. So like, take the transcript and we can sort of listen to a transcript and hand mark this is correct or not. So we know that's a gold standard. But the next transformation is transcript to a medical note. Now, how can that go wrong? So we talk about hallucinations, which is information in the note which wasn't present in the transcript. And we talk about omissions, which is clinically important information in the transcript, which hasn't been incorporated into the note. And then there are sort of two sort of failure modes. But there really isn't a very good way of describing exactly how to, what the nomenclature was and how we would actually like physically work that out. So we ended up, first of all, having to sort of define what that meant. So we use the term clinical entities present here versus that. Just trying to publish this paper now, actually, in Nature, talking about exactly this nomenclature and how we think about it. And then we said, well, when we make a model change, we just have to do this by hand. So again, like, talk about before, run before you can walk, but really, we had humans. So the concept of mechanical Turk, where you pay lots of people small amounts of money to do a task at scale.
Yeah.
We had clinical Turk. So we had a platform we still have it, called Creola, which is clinical research and evaluation of large language models and AI. And it was about 100, 150 medical students and doctors, pay them £5 a transcript and pair to look at the transformation, hand label any hallucination or any omission.
Right.
And we'd use that data to make this model change, yes or no. Too slow. It's too slow. It takes like 2 or 3 weeks and maybe £600, £700 to make a single prompt change. Like a single, like maybe even a word if you want to get really pedantic about it.
Yeah.
So then we're like, okay, well, what can we do with this? Okay, we have a system. Can we train an AI to do this? So that's what we've built now, and actually now deployed what we think is the world's first AI system in production, where we can see the live hallucination rate and emission rate of the AI models as they flow through our system, which becomes a really important part of the post-market surveillance. We're a class 1 medical device. We're moving towards class 2. Not possible unless you know what's happening in the real world and you can monitor that remotely. Now that's possible in a patient PHI preserving way. So, and into the future, like we built our own coding system now because that didn't exist. We might build action models that can control computers or choose tools because they don't exist. But it's very much an ecosystem of what's immediately available, what is the problem, how can we solve it, do we optimize for latency or quality? Generally, we don't optimize for cost anymore because cost just falls naturally, as does latency. So the only thing we really are optimizing for lately is quality. Understanding that whatever we choose now might cost us too much, but over time it becomes cheaper and cheaper and cheaper and cheaper. And the really interesting thing is now we're starting to see saturations in our choices. So, for example, speech-to-text model now does an hour of audio in 10 seconds. You can't really get much faster, right? Like 5 seconds, 10 seconds, if you've just done an hour consultation, makes no difference to you as a clinician. Can't really get much more accurate, maybe slightly. There's not much point optimizing it any further. So that would just be in the stack forever. We host it on our own systems, we can scale it, and it just sits there forever. Over time, we might want to evaluate other models and build other systems, but it's more the evaluation side that we focused on. I think that's where most companies in the like proper application layer will end up accruing most value.
Yeah. So you've talked about how you're a medical device level 1 at the moment, and obviously you're going for the next level. Is that where the sort of almost clinical decision support element comes in?
So it's interesting because I think the MHRA is still thinking about where ambient voice technology by itself, before you get to decision support, sits. In my view, it's always been a medical device. You can look at the guidelines in 2 different ways. There's definitely an area of grey. Lots of people are wondering about it. I think more fundamentally, I think I stole this from Leon Lindsay, who's one of the NHS ambient group, and I think he's a surgeon as well. And he said, if a patient can come to harm, if your thing goes wrong, then it's medical. And I think that's a really interesting way, that's a really interesting benchmark, especially I'm a practicing physician, GMC registered. Like, I do think about clinical risk in a very serious medical legal way as well. And I think that philosophy means, okay, well, there aren't really any good guidelines. DTAC kind of falls apart, the DSTPT thingy, DCB 160. These standards don't really apply to AI in the same way, at least in the probabilistic sense. So pushing us towards that direction is a really good framework. It's not perfect, but it's pretty good to keep us honest, to make sure that we're doing the right things, that we have the evidence base, that we can look at the accuracy, that we can report the data and the evidence for what goes through the system. Now, what's super interesting is making that decision just for ambient means now we're on the other side of the fence. So most companies in our space have spent a lot of time being on the other side. And that includes the big boys like Microsoft and some small startups as well. The other side of the fence is way more interesting. So like clinical decision support can be on the very sort of gentle end. Oh, you've just seen a patient with pneumonia. Here's the pneumonia guide. On the very complicated end, clinical decision support being like, you didn't finish your consult, but this is what you should have done. And I've asked the patient it already, and they've said this, this, and this, and this is what I'm doing. Is that okay? And then you can even get to autonomous on that sense. The problem, I think, with clinical decision support is not so much like, it's clearly a medical device. It's like not even a debate, but like, we don't quite know what even that very genteel end looks like in the mind of the clinician, especially the junior clinician. So I'll give you an example. Doctor, super junior, F1, F2, sees somebody on the ward, no one else around, not really assessed acute patients before, like for exams. Bit short of breath, listens to the chest, one on the right side, hears some crackles just on one side, goes, this must be pneumonia. Oh, that clever. And the AI says, you think it's pneumonia? Here's the pneumonia guidelines. But there's nothing clever about it's just literally said, you wrote pneumonia, here's the pneumonia. And in the doctor's mind, they're like, damn, even the AI agrees with me.
Right.
What do the guidelines say? They say, okay, let's do the sepsis 6, bang a litre of fluid in, do the lactate, do the oxygen cultures, job done. So they bang in a litre of fluid.
So it's confirmed that diagnosis.
And it's confirmed that diagnosis, and they're overly aggressive in their treatment anyway. Patients, the blood pressure's fine. You don't need to give them a litre of fluid. But actually, they're in pulmonary edema because you missed the other crackles on the other side, and actually it's a heart failure diagnosis. But you've overconfirmed it, you haven't checked. That fluid is actually now fatal to that patient, and they die. Now, in that scenario, whose fault is it? And I don't have an answer to this question, but it's fascinating. You can say it's the doctor's fault. They did the treatment. It's the AI's fault for not correcting them, or it's the AI fault for wrongly suggesting pneumonia when they should have thought about it some more. You could say it's the senior's fault for not being involved at the right time. But then maybe they weren't in the right time because the AI was involved. So like this decision-making needs really careful thought. And even I've seen now thinking about studies where we sim it and we try to understand if people change their decisions based on when we intervened with the AI and how it intervened. Some good evidence to say that senior clinicians rebuff AI, but they're wrong, right? So the AI will say the diagnosis is this. The radiologist is like, no, it's this. And they're actually correcting the AI. The AI is right and they're wrong. The really interesting question is, would they still be wrong if the AI hadn't suggested? Are they just being obstinate, right? Like the psychology of this thing is really quite odd. And we've never had a world where there were different types of decision makers in the same room. To go back to my point about the hierarchy exists for a reason. I mean, MDT's aside because that's chaos, but like, the average day is like the firm consultant, someone takes a decision and then wears the riz. So this co-model, we've not really even hacked for humans. So how do we want to do that? I think it's super powerful. We have seen some almost like decision support behavior without doing it. So I'll give you a really concrete example. So today you can customize the templates for the outputs. You can choose what headings are in the output for Tortus. Super important feature. Makes it very customizable for lots of different, dietitians and AHPs and paramedics. When we first started, we didn't have that functionality. So when we first started doing testing, it's basically built in a typical structure, always had a section for allergies. And then we started testing it for physios. Now, the physios don't normally ask about allergies because they don't prescribe. So it's not actually part of their workload. But we observed after 2 or 3 consultations of the notes coming out, so allergies not mentioned, which is a behavior of the system to make sure that box is filled with true information as opposed to trying to manufacture something. They started asking about allergies. So, and you could argue whether it's a good thing or not, but it's just an observation that you have changed behavior potentially in a good way when you otherwise wouldn't have. And then you just think about, a receptionist, for example, doing triage at the GP front door, right? No clinical decision support, but the AI will listen to the consultation and choose the right template. Is it a headache history? Is it a neuro history or whatever? And then asks about red flags that are represented in the template. And then after 2 or 3, you've suddenly got this amazing training vehicle where they're like, keep saying I didn't mention blindness to ask about when patients phone with headache. Right, now I'm going to start learning from that. So like, it's just a fascinating observation that you can then start learning from your own documentation, which isn't ever, it's always been a one-way street. Now it's a two-way street. Again, do we even understand the implications? And I think that's more why it is a medical device, even at this sense, because the cognitive workflow and how it interacts is not something that is well understood. Just to be more thoughtful about. And I think that's where the evidence generation, that's why we call Tortus. It goes slow and generate.
And how do you see the clinical decision support working then in Tortus in the future?
Yeah, I mean, we already have some use cases.
Which end do you see yourself?
So I think, so for example, but the super discrete problem-based thinking, one of our GPs said 70% of his consult, he will look up something on the Clinical Knowledge Summit. 400 articles about really common primary care presentations. Doesn't cover everything, for sure. So you've just seen a patient with, what's one of the ones that's quite common, UTI. There's CKS for UTI. And all it does is you might want this knowledge summary. So it just appears, it's just a link, right? Click on it, open it, read it if you want or not. Saves you 10 seconds, right? But it's a start. And then we can start going, okay, how good are we at suggesting the right guideline? How often do they click on it? How often do they need it? When they click on it, what page do they go to? Are they always going to the treatment section? I don't imagine many GPs will go to the diagnosis section, right? There's always that section on lots of those guidelines, but most people will look at that because they know how to do that bit, but they forget the treatment. If we surface it in, do they need to click on it? Do they use it? If we incorporate it into it has to be like a gradual, and it has to be product-led. It has to be by the user saying, I don't like this, I do like this, this was useful, this wasn't. Can go really super deep. I mean, I used to always look up the ESC, European Society of Cardiology guidelines for most patients I would see in secondary care, because tertiary care more accurately. Because at that point, that specific patient has been through a number of different runs of the system and really wants a definitive guideline-directed treatment. And the specialist center's expectation was we would deliver excellence at the highest level. But it was very hard for us to learn, to ingest, to have updates. We used to have journal clubs on the guidelines every week. There's a lot to learn. So wouldn't it be great if it was hey, this is a relevant guideline for this patient. These are the bits that you should read. This is how you ground your knowledge. So there's medical education piece to be built around the live environment and the offline environment as well. So I think it's just a question of slowly, surely, and with customers, as it is always the answer.
And I mean, what's amazing is with a technology product, you can have so much of that live user behavior data. Like you said, what are they spending more time on? Which page, which section? What are they reading? What are they not reading? And as much as obviously they can tell you what they want, you can also see it.
And also people don't often tell you what they want.
But they don't always know.
They don't know. Right? There's that Henry Ford quote, if I asked people what they wanted, I would have built faster horses. I think about that all the time because there are some behaviors when we ask people what they want, but they don't. So for example, we have a dictation feature. So one of the behaviors we notice is people were pressing dictation before they press consultation. Right. Because consultation, what does that do? Does it call the patient? Oh my God. But dictation, I know what that does. So I'm going to click that first.
It's clear,
so it's clear and it's trusted. But then it takes them to completely non-AI part of the stack. But then people started asking for smart phrases. So they wanted to say things like dot normal exam. And then it would populate, chest clear, heart sounds normal, abdomen soft, non-tender. And then we looked at this for ages and said, look, users have asked for it. It will save them a bit more time than we're already saving them. But from a clinical safety perspective, this is an error generation machine writ large. And we know that happens in templates. We know that 60% of medical records, when you're copied and pasted, are full of rubbish. Why do we want to propagate this? Why are we trying to build a faster horse? So we made an active decision to the chagrin of some of our users who are like, no, other companies do this. But they're not thinking about the corollaries of this. At scale, this could get really dangerous really quickly. And this, it's responsibility of the clinician. Doesn't, 3 clinicians down the line, that responsibility disappears and the record is the record. If you said normal heart sounds, but they have a murmur and a fever, that's endocarditis until proven otherwise. If they had that murmur 3 sessions ago, that's not endocarditis and we'll look for another source. So that makes a massive different section. And that's why we decided to not put that in the system.
That's really interesting because I think that's often a debate in tech, isn't it? Where, my users want this feature, I'm just going to build it because I want to satisfy them. I want to, I want to get that traction. But to really think through the consequences, as it were, especially, I guess, in health tech, becomes so much more important, right? Yeah. No, that's really interesting. So tell me how. So at the moment, Tortus integrates with, I understand, EMIS and System C.
No, Epic.
Oh, okay.
And then working on EMIS and System 1, possibly through a partnership, but yes.
Okay, great. Well, often in this space, I hear people talking about integration as one of their biggest challenges, especially with big EPR systems like Epic. So interesting you've said Epic. So tell me how did you manage to make it happen?
So Epic's interesting because you need to have a site. And I think where people get unstuck here, it's very much chicken and egg. And even Cerner's the same, actually. If you want to build a test integration with Cerner, you have to convince a site to give you access to their sandbox before you can even test it.
Yes.
That's ridiculous. And again, things to unlock as a top level, there's companies in the US like Redox, for example, that exist. They don't really exist here, but they just become your integration partner. But actually, the Epic journey was pretty good. I'm not sure how much. It's a very litigious company, how much I can tell you. But it took us about 6 months to do it.
Right.
There was a lot of going back and forth about checking and signing docs, but actually the ecosystem's really good in the UK now. There's 9 trusts, kind of working with all of them. And that gives us a bit of lobbying to build more and get more features from Epic. We did initially have a thesis that we shouldn't integrate and we should go over the top. The problem is the system wants you to integrate. Your customer wants it, right?
Yeah, exactly.
They don't trust, or at least haven't seen the value of, other ways of getting the data into the system like RPA or intelligent versions of that.
Yeah.
That means if you're an enterprise company, integration is a table stakes, it's required.
Yeah.
The other issue with the EMIS and System 1, obviously, is that integration exists. You have the IM1 API, but then that is a very long assurance process. And to allow data to flow through your system into the national record, which is essentially what you're doing, there's a long NHS assurance process. For a while, they were just completely pausing on AI. Now they're coming back to it, but they want to be a medical device. There's a lot of complexity around getting that done. And then you see other companies who already have the IM1, they're just throwing AI stuff down it because they already have the API. So there's a bit of asymmetry in terms of safeguarding new companies versus allowing old companies just to crack on. But it's a very odd industry in that you're selling to a customer and they're like, I love what you're talking to, but talk to those guys.
Yeah.
And those guys are like, we don't care.
Yeah, exactly.
So
what's their incentive, I guess?
What's their incentive?
Yeah.
And I think, it's a very polydimensional game of massive friction. There's massive friction in healthcare at all sides. There's no money and people need healthcare and enterprises are slow to change and the champion just quit.
Yeah.
And then on top of that, they're like, okay, integrate with that company. Okay, well, that takes a year, right? But I think once you've got over that and once you've built some repeatable motions, and that's why actually it's a really good idea if you're thinking about doing this, is pick a lane, right? Pick a system, align your customer. So we did an Epic integration because we were based at Great Ormond Street, went to all the other Epic sites and just said, look, we have this integration, we can deploy it. Let's have a commercial conversation. Much better conversation than we don't have a Cerner integration, but we'll build it for you later.
Yeah.
And we still can do that, but it's just it slows that process down. They can't see it live. They can't see it living. And that's a big gap, especially when you're a startup and you're constantly fighting that battle of, I love what you're doing, but no, just...
Yeah.
And we all know that pain of how do you get to credibility before you have customers? It's how do you keep solving that chicken and egg? And it's incremental. We have a little bit of an integration, we can make it better if you didn't favor that. The one thing I would say, which is the best advice I got from the Digital Accelerator peers, do not do free pilot. Just do not do it.
Yeah.
Just take the loss. If a system says, we ain't paying for this, either you're building the wrong thing and I've got no money. But either way, that's not going to happen. And it doesn't matter how long your free pilot is, it still won't happen. And as soon as you start pushing people and say, no, you have to pay for this because it's a thing you need to buy for. People are like, oh yeah, we buy things. Yeah. Go to the shop, you buy bread and just eat it, you buy it.
Yeah.
And it's really, the conversations I've had more recently now, we've been much more clear about that.
Yeah.
People go, oh, okay, 1 second. And they go into the cupboard and they put I'm buying stuff out on and they go, let's have a commercial conversation. Same person, same budget. different mindset.
Yeah.
But also it knows that that when money's going down on the table, you can build that integration. You buy an annual contract, we'll build your integration. Much better conversation than, well, when you integrate it, we'll see if the free pilot works.
Yeah.
We want to evaluate it.
Yeah.
And it's like, you just have to be a little bit more, bullshit.
Yeah.
You'll get to know, but you'll get to know faster, way faster, months faster. And then you eliminate that customer and you move on to someone who has money or has interest or has,
Yeah, you save your energy, don't you? Yeah. Somebody once advised me exactly the same thing. Don't ever sort of do free pilots. And he said, I would always do a 6 months pilot for 8,333 because plus VAT, it's just under 10K, which is the threshold that a sort of middle manager can sign off within the NHS.
But also the odd amounts thing. Do you know this thing?
What is that? Oh, yes.
Always write an odd amount.
Yes, sorry, yes.
Because it looks credible.
Exactly. You thought about it and it's very specific.
10 grand is like a dodgy deal behind a pub.
Yeah.
£9,956 is legitimate money. And it makes no sense.
Yeah, exactly. Right? Exactly. No, but I think that is really good advice around sort of don't do free pilots. Just coming back to sort of the integration piece and like you said, you picked one lane, you made that happen. But I guess going back to my question of what is the incentive for an Epic or a Cerner to integrate with a small niche business just coming into the market?
I mean, they have business
How do you make that happen?
I mean, you just pay. So like, the vendor services system, I think Oracle will have an orchard or a garden or something. And you pay to use it.
Right.
So their business model is, well, the bigger you are, the more money, it's passive income for us.
Yeah.
It's not actually that complicated, to be honest. The hurdles are pretty, so you need a team, right? You need a dev team.
Yeah, of course, yeah.
Also, just to go back to your point about, like, the other thing is the partnerships. You always think, we'll partner here, we'll partner there, we'll partner here. Been down this route many times. And it's just really hard for a startup where your fundamental requirement is to survive.
Yeah.
If you work with a company who aren't fundamentally surviving, they're just static or they're massive or that asymmetry of need and alignment is really hard to navigate.
Yeah.
And if they go one way and they're massive, they will just kill you by accident. They'll just stomp you.
Yeah.
Oh, it'll take 6 months.
Well, they won't even think about it.
They won't, and they won't even think about it.
Yeah.
So I think like we have also looked at, partnership models, share this, we could share that, but it's just almost too high friction. And once you built it internally once, then you're a credible company.
Yes.
It's hard to do the first time. Another Paul Graham thing is like, if you're building a startup and if you have a choice to do the easy or the hard thing, always pick the hard thing. Because if you fail, you'll learn that that's a hard thing that doesn't work and most people haven't tried it, so that's valuable knowledge.
Yeah.
And if you succeed, most people won't have done it.
Yeah.
And therefore, either way, it's valuable. Whereas the easy thing, if you fail, well, then what are you doing? And if you succeed, well, what did you gain? Not very much.
Yeah.
So I think, like digging in and not being tempted to go the partner route in that sense is probably long-term the best, but people take shortcuts.
Yeah. So, Dom, you recently visited Downing Street, met with the Prime Minister and various other colleagues from the AI ecosystem. So let's start with asking the most important question, what's he really like?
So I didn't meet Keir himself. He popped in. It was like an event for, there's like 200 people.
All right.
I did meet Sadiq Khan.
Oh, nice.
And I met Wes Streeting as well.
Yeah.
I haven't met Sadiq Khan.
He's really short.
Yeah.
I can say that, You know how they say,
but
if you are it, you can say it.
Do you know what? Super sharp.
Yeah.
Right. So like, to go to your point about, earlier in the day, I was like, I pitched one, I didn't get it. Sadiq got it instantly. Like, doctors love this, right? Hey, Patrick, called Patrick Balance over. And he was like, and I was like, oh God, it's like, yeah, just to do a quick pitch in noisy room. Obviously getting better at those skills. I think it's really interesting. Like, there's a real buzz around. It's almost like a North Sea oil moment. Like, we've discovered this resource at a moment of new government, new plan, new technology. Let's go hard on it. Matt Clifford wrote this AI Opportunity Action Plan. We messed that up now. Action AI Plan, whatever it is. A plan.
Yeah.
And the government are saying, we're going to adopt this at scale. And there was a lot of optimism. And I think, it's really, I've never been down the street, so I don't know what the mood normally is. But just talking to other entrepreneurs and other people in the scene, they were like, well, this isn't something that we would ever thought, never invited, just at the back end of Shoreditch.
Yeah.
Where are we now, Bo? Like, that's where, the innovation's really happening. But to suddenly be like invited and to talk, it was a real spectrum of people just starting out.
Yeah.
People, I saw people from Meta and like they're moving companies here and investing in London as well.
Yeah.
So again, it's a great opportunity, for the startup ecosystem, but also for tech in general.
Yeah.
But then always the proof in the pudding. So what happens next?
Yeah.
I think actually money-wise, interestingly, can flow into infrastructure and supercomputers, etc. Some of the process things, right? So like, I was at a dinner recently with Tim Ferriss. And
amazing.
Is he cool? He's super cool.
Yeah,
he's a doctor, right? So like he gets it.
Yeah.
And he loves ambient, so he really gets it. But he's sort of helping write the digital plan. I sort of sent him an unsolicited email about my thoughts about how startups could benefit.
Right.
But it was really about like, what would actually be super useful is set the bar super high.
Yeah.
But once you pass it, that's the only thing that NHS people can buy.
Yeah.
That becomes the procurement and the evaluation. You don't ban free pilots. Don't let people engage in them. Because also, if you think about a free pilot, like generally the contracts that you've signed aren't great. So, indemnity, medical risk, SLA, uptime, the robustness of your solution, all of these things don't get sorted out in the way that they normally would.
No, they wouldn't. Yeah.
You don't get much engagement because you've not spent money. No one's on the hook for it. So no one wants it to work internally. You often will lose your champion. So just ban them. This doesn't really help anyone. And build that ecosystem and take that friction away.
Well, that's the challenge in the NHS, though, that there isn't a lot of, two things really. Funding is tight in general, but there isn't like little pots of money for innovation or innovation testing. And sort of couple that with this real, fear of failure that exists in general sort of healthcare means that we're too scared to try something new. We're too risk averse, somewhat rightly so, patients might get affected. Well, fine. So then do a small pilot, do a safe pilot. And if you fail, then fair enough, that innovation perhaps wasn't right or needs to change or improve. But it feels, and, we do a lot of work on the front line. We work in secondary care. And it feels like there is very little space to try new things. And to be fair, if there was one thing that drove me out of the NHS was that I felt like I didn't have that space to try new things. And the only way I could do it was come outside the NHS.
Yeah, it's such a good point. There's that Warren Buffett quote, isn't it? It's
gosh, you're full of quotes, aren't you?
I do too much podcasts. What's it say? Show me the incentive and I'll show you the behaviour.
Right, yeah.
So I was thinking about this a lot today about why we love free pilots so much. And I think the incentive is a lot of the places, where we're thinking about innovation or driving or change, whatever, their outcomes are, we trialed X this year. We're measuring the number of pilots. We're measuring the number of companies we engage with. We measure. But no one's measuring what gets deployed, right? No one's measuring the outcome. And I think if you could you put some more resource behind it.
Yes.
If you thought this is the change department, the change department's mandated to use new technology to achieve X outcome. Whether it's in the A&E department, we need to decrease the 4-hour wait.
Yeah.
So that is the goal. That's what the money's for. Go out into the world and find whatever you want that will do that. But then you buy it, right?
Yeah.
Because it's at the end of the year, they'll be like, well, did you change that thing?
Yeah.
Well, we tried 10 things. And we're like, well, that actually sounds like a worse idea.
Yeah.
Why don't you just try one thing and make it work?
Yeah.
Right?
Yeah.
So I think the incentives aren't quite right. And then the accountability doesn't flow and the outcome doesn't happen.
Yeah.
But we saw this in COVID. The system is crazy. Like when the incentives there and the resources there, the system can move like anything. And that's because it is coordinated and people do care and there is goodwill, but it's just about alignment.
Yeah.
A friend of mine was anaesthetist up north during COVID and she used to anaesthetize patients in one of the, the pre-op rooms, what are they called now? Like the anaesthetic room. But the clock was behind her. So the patient comes in one way, she can't see the clock. So she's constantly having to turn around. She's like, this is so annoying. Like, I just want to see how long the patient's, had the tube out so I can get the tube down. So she put an request to the state to move the clock one wall to the other, unscrew it, rescrew it, right? 3 years. Hadn't been moved in someone's backlog. And then she said, in COVID, we knocked that wall down and we built a 12-bed resus unit there instead, right? So, the walls disappeared, the clocks moved, there's 12 beds in there. And we saw that at scale because the money was there, the incentives were there, the alignment was there, the need was there, and people actioned it.
Yeah.
Same thing needs to happen, especially now. We're at crisis mode.
Well,
right?
precisely. And I think that's what it is, isn't it? it's almost like the NHS is in its best form in a crisis.
Yes.
But come to sort of day-to-day average management, just getting all of the sort of basics right feels almost harder in the NHS.
I just wonder, I think, is that a Britishness thing?
I don't know. And like you say, like what I think people need to realise, and I don't feel like they realise enough, is that we are in crisis. I know it's not a COVID-style crisis, but people are being impacted by, the waiting times, the terrible waits in A&E. Which one of us doesn't have a story, of a loved one waiting ridiculous hours in A&E? My mum, several times over, everybody I speak to has an aunt or a brother or a sister or somebody or the other. So I feel like, and I don't know where that sort of recognition can come from. Yes, we've had the Darzi report, but I feel like, it was kind of like up on the news cycle, and then we seem to have gone back again. Having said that, I don't know if you've already caught the news today, so this sort of dates this episode ever so slightly, but Amanda Pritchard has quit.
Yes, saw that, yeah.
And it's, so you've recently met West Streeting. So we were just reading the article, and it said something like, the kind of reforms that the government wants to bring in, especially West, she feels perhaps she's not the right person to bring them forward. And so Jim Mackey is taking over. What are these reforms, Dom? Do you know? Did he tell you at your visit?
I think...
What do you expect will happen?
What do I expect will happen?
Yeah.
Such a good question. Optimistically, pessimistically. I think something will happen, right? And I think that's not like as vague a statement as it sounds. But often nothing happens, right? True. Often, there's a big announcement, it goes down to the department, nothing happens, right? Nothing changes. So I do think something will happen for the reasons I said. The winds of change, technology, demand, requirements. Need to make some moves. I think, I don't know about appointments. I don't know how these decisions are made, and I'm sure there's lots of reasons behind them. But it does mean there's opportunities to new mandate, new CEO, new something to change. Now, I think what often happens is it gets a bit gimmicky. And that's where I always worry is like, we're going to bang the drum, we're going to raise awareness, we're going to run a PR campaign, yada, yada, yada. I've worked in the NHS for like 16 years. I've seen many, many cycles. We're going to close all the A&Es and make it efficient. Actually, what happened is you close my A&E, let down here, and now I have to see all these patients on my other shift over here, and it's worse, right? Or 7-day NHS, that was a great one. Remember that one? Yeah. That was great. 24-hour NHS. But like all these things and like the actual outcomes, I think what will change is willingness to start solving real problems because it's become easier to solve.
Well, yeah.
Technology, AI specifically, is tremendous leverage, and it's actually very powerful if you can get it deployed at scale. And it's also something that I think the public kind of expecting to see now. Like they're using AI at home, they want to see it in the hospital system, they want to see some problems being solved. But it's also interesting on the macro level to be like, what is the solution? The healthcare system today is set up 60, 70, 80 years ago.
Yeah, exactly.
Practice of medicine, of seeing human clinicians, human patients. When, you had a heart attack, let's be honest, mostly you died. In the 50s, that's what happened, right? If you had GI bleed, you probably died. So there's no comorbidity, there's nothing to fix, there's no need for a 24-hour service. Cancer treatments didn't exist. Expensive scans didn't exist. So like the whole system is now set up for a world where actually there wasn't much resources. The average doctor only lived for about 2 or 3 years after they retired. So like their lives were crazy.
Yeah.
So we need to really rethink about what we can do. And again, AI is fascinating because it changes 2 fundamentals. One, the amount of work a single human being could do previously was 1-to-1.
Yeah.
Now with AI, is that 1-to-2, 1-to-3, 1-to-4? I don't mean they physically do more work. I mean, they can look after more patients. Yeah. They can monitor patients remotely. There's a lot exponential leverage you can achieve. So you can do more with the human staff that you have or make them do less of the stupid work.
Yeah.
But 2, knowledge is distributed.
Yeah.
That is something that's changed. You can go back 20,000 years, right, to the shaman or whatever we had, where one person was wisdom. They held the arcane knowledge.
Yeah.
Now knowledge is distributed, And we had Dr. Google. Now we've got Dr. ChatGPT, but you could almost argue in many senses, sometimes Dr. ChatGPT is going to be better than the doctor. And that world will come really, really, really soon. So again, how do you set up healthcare services if people are coming with your diagnosis and the diagnosis is right? Right? That's a whole different world.
Yeah.
We need to start thinking really about what the future state is, as well as what the short-term problems are.
Yeah.
It's a tremendous opportunity for them. I hope they keep it simple. I hope they pick some simple technologies and put some money behind it and measure something that matters.
Yeah.
And then that will make the needle move. But we'll see.
Yeah. I just hope that it is an investment in things which just make faster horses.
Yes, exactly.
Because certainly from my experience, as much as there is definitely new innovation and, health innovation networks in particular, that's their job. They're bringing so many great things to the fore. It does often feel like when you're talking to hospitals about, we can come solve this problem, but have you thought about using this innovative technology which can support? No, we don't want that. Just make my paper process digital. Do you know what I mean? Like it's just do the most basic thing, but a little bit faster, rather than find another tool which will, do that 1 to 2, 1 to 3 kind of productivity. And I really hope that if they are going to take that leap, they take it that far, as opposed to just, paper to digital. Give me a spreadsheet instead of paper.
Exactly.
So obviously you're doing so much work, in this space around AI. You've also recently, I believe, held an AI Academy for an NHS audience. Tell me what was that experience like, and what kind of questions came out? What kind of challenges were people talking to you about?
So we ran a series of 5 webinars. What is AI? How to evaluate it? Clinical risk and adoption. And actually, the person who was doing that was sick, and then I actually took it over at the last minute and then decided to talk about product management, which is actually a really interesting way to think about adoption of product.
Yeah.
Because that's how we think about it as a company that builds stuff. We should all think about that. Like, ultimately, if you want to implement change, you have to get the clinicians to love your product.
Yeah.
It doesn't matter if that's a new guideline or a new drug chart or a fancy AI tool. Don't use it. It's a waste of time. And we're not vicious enough about that discipline, getting feedback and iterating it, so people actually do want to use it and it does solve their problem. I thought it was a fascinating lens to start thinking about proper change in hospital systems. Yeah,
no, absolutely. And from your audience's perspective, were there any specific or notable challenges that they were voicing to you in this space?
I think there's quite a few themes that are pretty common. So one is around governance. How do we do the governance? And we have a whole stack of paper, but it still takes ages. And we've been approved, 20 ICBs at this point, but it still takes time. I think the GPs, they have double governance. They have the regional governance and they have to do it again themselves.
Right.
That's a ridiculous system of devolved responsibility. I think cost. Where's the money? But I think the business case for a lot of these tools is pretty obvious. As soon as you can get into the workforce budget, the productivity budget, and you can be confident in that. And then really interestingly, lots of people go, I already do this, or sometimes I do this. And we're thinking, actually started learning a whole bunch about what people are already doing off book with tools and sort of validating a whole bunch of new use cases. So no, it was a super good experience. Everything's still on there. You can go and watch that. We'll run another bunch of sessions after the summer and do something.
Brilliant. I think I'll be joining. Can we join?
Yeah, we'll go.
Non-NHS?
Yeah, of course,
good. Based on your experience as a healthcare professional, then sort of becoming an entrepreneur, if there was somebody out there who wanted to go down this journey, they have this idea, they want to take that next step into it, whether AI or not, but generally health tech, what would you advise them to do sort of almost as step one?
I think step one is the gap between what you think and what you can build is getting smaller all the time. So there's AI tools that help you build proof of concept apps. I wouldn't fall into the trap that you think you can build a sustainable, scalable product, because the gap between proper engineering, robustness, and understanding the code when it breaks and using something like Lovable, which will just generate it for you, is massive. There's a whole debate to be had about AI-generated code. Are you actually building something, or are you just building something that you need AI to fix for you because you don't understand it? And that's not sustainable. So start, number one. I think number 2 is like there's lots of opportunities for hackathons, for meeting people who are interested in the space. Accelerators are obviously a great thing if you want to get into it. Third and most controversially, if you really want to do it, quit your job. And the reason for that is, founding is a full-time game. It's really hard to do it half the time.
Yeah.
It's a bit like a terrapin. It will grow to the size of the tank that you put in it. But quitting your job is like jumping into the ocean. Like it's cold, it's really, you might drown, but like you're there and you're going to swim and you're going to expand to the size of the ocean and you're going to grow.
You're going to give it your all.
And you're going to give it your all. And then I think the worst, again, to go back to my original point about like, what is one of the worst things that you can do is like, you want to do something, but you don't go after it full-heartedly. Yeah. You don't ever know that you could do it and you probably won't ever be able to do it, but you spend a lot of time and effort and life in that limbo state. So I quit my job, took an extra mortgage to like pay the bills and 3 kids. And to be honest, like I learned so much that even if it had all failed, I'd just go and do it again and just do it better next time. Yeah,
it's amazing. And finally, just when you look back at your entire journey, obviously lots of ups and downs you've talked about already. If there was one thing you could change, appreciate everything is a learning experience, but if you could change and do it differently, what would it be?
Yeah, I think to answer this question, I think it's a really good one. So the long answer is probably focus. So when we first started, we're sort of, okay, got great AI technology, but actually we're kind of building 2 things. We're building these cool deep tech technologies. We're also building these tools. We're selling to primary care, we're selling to secondary care. We're in the UK, we're in Canada, we're in the US. And even I was talking about now, like, what are we doing? But I think what we're doing is we're looking for the market.
Yeah.
But the problem is, if you're not building one thing and you're looking at multiple markets, then you're sort of creating a multiplier when you don't have that much resource to search. It's actually better to do the opposite, to invalidate, right, can we sell to UK GPs? Yes or no? Actually, no, because it's really hard to install it. Let's go sell to Canadian GPs. This is actually what we did. Let's go sell to Canadian GPs. Yeah. Actually, UK hospitals are better. Should we go there? But we didn't do it in a very focused way. It's actually only the last couple of months. We said, we're just going to sell to these customers. And once we've cleared that quarter, yes, no, then we'll go to these customers and we'll go to these customers and build that repeatable motion. But now everyone's super clear. What are we building? We're building enterprise features for epic hospitals. Much easier to understand that.
Yeah.
Are we going to build complex research-based things? No, there's no desire appetite for the customer because we know who our customer is. So definitely not a, that was and then everything else is aligned in terms of who you hire, why you hire them. It's much easier. And it's just if you're wrong, change your mind.
Yeah.
But like have a decision, have a hypothesis.
Yeah.
And then the short answer to your question is nothing at all. And the reason I say that is like, I'm not sitting here without those scars, without those mistakes, without that learning. And then that is the value of knowing what the importance of focus is.
Yeah.
I just focused on something I wouldn't even know that actually going scattergun later was a bad idea.
Yeah.
Now I do.
Yeah.
So, yeah.
So actually nothing at all.
Nothing at all. Yeah.
Well, that's brilliant. That's a perfect point to end the podcast on. But thank you so much. I bet, as I say, I couldn't even ask you all my questions because it's been a fascinating discussion. I hope you'll come back someday because there's loads more for me to ask you. But thank you so much for your time today, Dom. It's been so lovely to have you.
Yeah, thanks.
Thank you. Thanks for listening or watching, everyone. What a great conversation. I genuinely could have kept speaking to Dom for another couple of hours at least. That bit about Dr. ChatGPT being better than your doctor, that's going to sit with me for a while. If you enjoyed this, please hit subscribe and let others know who are interested in these stories of absolutely fantastic innovation spreading across our healthcare sector. It really does help us reach more people who want to hear these stories and hopefully inspire them to do more similar things. Thanks again for watching. I'll see you in the next one.